The cost of the entire genome of one single person at that time was $3 billion. And it took 5 years to be performed in several countries around the world. This had a major change when we were able to have the next generation sequencing techniques, which came around 2006 and 2010. First for research and then to the clinic. The cost dropped dramatically. Something that took 5 years to be performed in one person now was taking 2 weeks to be performed. So not only the costs dropped dramatically, but also the quality of sequencing, the quality of reading. And we were able also to add the possibility of reading large deletions and copy number variation changes, not only by the next generation sequencing, but also through another technique that was developed at around this time, around the 2004, the MLPA, which is a multi-ligand proband assay. And these are responsible for 5 to 10% of all alterations that we find when we're looking for a germline pathogenic variant. And after that, we had several other techniques that are being used in several centers, mostly for research, which is a third generation or a next generation sequencing. The ion torrent there is already available in most centers who work with sequencing. So the curve was the slope was very high, and we were able to develop a lot in the last years. We came from the chromosome evaluations to the sequencing and the next generation sequencing. And in 2021, we're even able to perform whole exome sequencings and whole genome sequencings, as well as RNA sequencing. But the question is, we should not perform whole exome sequencing and whole genome sequencings, even if we have them available to our cancer predisposition patients and families. And why shouldn't we do that? Isn't it better to have a lot of information? And the answer is no. The answer is no, because we don't know how to evaluate all this information. And it is very complicated to have a lot of data and less coverage, which is the case for whole exome sequencing, compared to the next generation sequencing techniques for a specific panel. And so just to resume this all, next generation sequencing panel for certain genes is the best technique that we should use now. So how much does this cost now? I'm going to speak about Brazil. 1,950 reals, which is the equivalent of $250 in most centers. This is a very low cost if we compare it to what it cost in the past. This is very easy and fast to collect. From 5 to 21 days, we're able to have the results in our hands, and we are able even to provide our patients who are waiting for surgery, for example, even a best approach for the surgeon, and that there are options for those individuals. Sometimes even prophylactic surgeries can be a possibility that should be discussed with the surgeon even before the surgery after a cancer discovery. So I have developed these 5 rules of thumb, which is everything that one should do prior to perform a panel testing. So first of all, never forget about genetic counseling. Genetic counseling is not just giving a bunch of information to a patient, and many oncologists, many mastologists, breast surgeons think that they are able to do the genetic counseling. And the answer is yes, sometimes they are, if they have enough time to do it and enough training to do it. But the best situation is if we're able to work as a team, to have a genetic counselor, to have an oncologist, and for instance, if we're talking about colorectal surgery, a colorectal surgeon, or any other surgeon, that will be involved in the treatment of this patient. Second point, it is fundamental for you to choose a certified lab and to check the methodology that this lab does. Is this lab a lab that is certified? If it's not certified, you have to check the methodology very deeply. What I usually do is whenever I have a lab that I've never seen before, I call the lab and see what is the depth, what is the coverage. Do they do confirmation of alterations with MLPA, large deletions, and other indels that can occur in those individuals? And I talk to the person who is responsible to see if they do a correct method in their laboratory. Another information that is important is whenever you have a cancer, a family with multiple cancers, sometimes you perform the testing, you see 3-4 generations of people attained by cancer, multiple cancers, the ages of diagnosis as the generations occur, father, and then the son, and then the grandson. The cancers occur every time earlier. That's called anticipation. So you have clinically a clear diagnosis of a hereditary predisposition to cancer. But when you perform the genetic testing, the genetic panel, you don't see an alteration. What can you do in this situation? Should you tell your patient, no, you don't have anything, don't worry, you'll never have a high risk for cancer? That's not correct. If you have something occurring in that family, first of all, you're going to test someone else in the family. If the person had already a cancer, you're testing someone who had an earlier onset cancer. If that person wasn't available, sometimes you need to tell that family, well, we tried with the techniques that are available right now, but you should come back in 1 or 2 years or 3 years, because maybe we'll have newer techniques or better ways of looking at your DNA to try to find what alteration there is. Maybe we don't know it right now, but in some years we will be able to find some kind of alteration. So be very aware of giving a negative result to your patient. Sometimes it is misunderstood. Sometimes the patient thinks that he doesn't have anything, and that's not correct. Clinics is really very important, and we should stick with our clinical diagnosis, even though we're not able most of the times to conduct any kind of regular screening in those individuals, and most of all, never offer prophylactic surgeries when we don't find a genetic alteration in those individuals. Another point that is very important is regarding variants of uncertain significance. And I'll talk to you a bit more about it in the next slide. And the duty to recontact. What is it? Duty to recontact is the importance of whenever you have a patient that was tested with some technique that is now obsolete, or some technique that now may be lacking knowledge about, for instance, large deletions, you have to go back to your patient. You have to call your patient and tell him, well, we have new techniques. Maybe we'll now be able to find an alteration. And duty to recontact is important also in variants of uncertain significance. So what is a variant of uncertain significance? It's some change in the DNA that may be very similar to a pathogenic mutation, but that we don't have enough information for now to classify it. But it's very important to understand that whenever a variant is classified as a variant of uncertain significance, usually it went through already a pipeline to define its pathogenicity, and it's most likely benign. In most of the cases, we have several ways of understanding what those variants are. And here I just give you an example of last year's genetic tests that I performed in our group. And among all the genetic testing that we did, which was over 500 panel testing, we had 159 individuals who were, I'm sorry, 171 individuals who were reclassified. From those who were reclassified, most of them, the reclassification was from variant of uncertain significance to benign. So this is just to confirm to you, usually a variant of uncertain significance is something that we should keep as uh, uh, something that we never take any action, and especially never take any surgical action to those individuals. Even if you find a variant of uncertain significance in BRCA1 or BRCA2, you'll never be able to tell your patient, oh, you should do a prophylactic surgery of the breast or of the ovaries. No, you don't do that. What is interesting, and I classified those here as downgrades and upgrades, but among the 171, I only have 6 individuals who are reclassified from a variant of uncertain significance to a pathogenic change. So it's really the minority. And don't worry, the lab is obliged. The duty to reclassify, to recontact here is from the laboratory. He is obliged to call you and to call the patient to inform that the variant of uncertain significance was reclassified as pathogenic. This is just something that I want to make you all aware. If you work with cancer genetic predisposition, or even with genetic syndromes, you probably have already a patient called and told you, well, I did a very nice exam in the United States. It costs less than $100, and I bought it in the pharmacy. I don't know if it's frequent in your countries, but here in Brazil, it's becoming more and more frequent. And there are some labs that are selling it here too, which is the possibility of starting a DNA analysis to try to define your ancestry. And it would be even fun if it would stop there. It's very interesting to know what is your DNA composition, if you're mostly European, if you're from Asia or from other parts of the country, but usually they don't stop there. After you perform this first part, they send you an email proposing with more $50, they'll give you important information on your health. And frequently they send even information on cancer risk and information that is not given after genetic counseling, and information that be very, very misleading. So I really tell my patients not to do those testings because they're very tricky. And together with very important information, for instance, they talk even about Alzheimer's disease, which is unethical. We're not supposed to do any genetic testing and confer any slightly increased risk, as in this patient that I've seen, if I don't have anything to do to my patient. So this brings so much angst and fear in those individuals. And in the next page that I've seen this, there is, for instance, completely unnecessary information like ice cream flavor preference. And the following page, we have even BRCA1 and BRCA2 Ashkenazi Jew mutations for BRCA1 and BRCA2, which are really, really important. And they give the same weight of information as an ice cream flavor preference. So it's really nonsense. It's really dangerous. And please don't do it, and tell your patients not to do it. This is recreational genetics and it's not serious. So what are the benefits of getting germline tested and to get good quality germline testing? First of all, Let's go back to that patient that I presented in my first slide. She was a 57-year-old metastatic breast cancer patient who had a metastasis in the lung and in the brain. And she had a previous history of breast and ovarian cancer as well. And she was found to carry a BRCA mutation. So now we have drugs that are extremely useful and that may provide to our patients a very, very good outcome and a better quality of life whenever it is used in patients who should have a BRCA1, a BRCA2, and a PALB2 in case of breast cancer, and also ATM in case of prostate cancer. For ovarian cancer, for instance, there is an increase in survival with good quality, with good quality of life of 3 years in those who can use this drug. Also, the second benefit I would like to raise with you is, for instance, this is another patient who came to me with a BRCA1 mutation. She already had it, and she had breast cancer at the age of 36, breast cancer at the age of 40, and she came with her two daughters. She's now, I'm sorry, I raised the age here. I can remember, I think she's like 60 or 70 or something. But her main question here was, okay, I have a daughter who is a carrier and a daughter who's not a carrier. What should I do with them? So clearly here we have loads of benefits to do with both individuals. First of all, this girl who is 20 now, she has exactly the same risk as the rest of the population. She can go home and not think about breast cancer screening or any other screening because of a high risk for developing cancer. She will need to do all the screening that the general population does. And what about this girl here who is 29? Everything changes for her. She now needs to start with magnetic resonance of the breast, followed by 6 months later, mammography and ultrasonography of the breast. And whenever she reaches 35 years old, she has a recommendation, and this is clear even we as genetic counselors and medical geneticists, this is one of the few situations where we should recommend something. We have to be directive. And why? Because these individuals who carry a BRCA1 mutation, they are at life risk if they don't do a prophylactic surgery of the ovaries at between the ages of 35 and 40 years old. Ovary cancer in those individuals are mostly serous type ovary cancers, and it is not possible to screen those individuals. We cannot have an early detection of ovarian cancer. So it is clearly indicated for this lady. And we have other good things to offer to this woman if she performs this ovarectomy at the age of 35. She may be counseled about the possibility of doing some breast adenomastectomy, bilateral mastectomy, but that is a possibility and it should be only offered to those individuals. We're back to South America and Brazil. Should we do the same as we see around the world? And our answer is yes. We had this publication now last year in March, and the only difference we found from our management recommendation and those of the American Society of Clinical Oncology was that here in Brazil, we have a higher occurrence of Li-Fraumeni syndrome that leads to not only breast cancer risk, but several other cancers, sarcomas, brain tumors, and all. So we had to add screening for those individuals in a different setting and make very clear that Li-Fraumeni syndrome patients are not a risk for ovarian cancer. So, other than proposing the possibility of risk reducing mastectomy and contralateral reducing mastectomy, we talked about the possibility and the recommendation of salpingo-oophorectomy. What else can be done to that 29-year-old lady? If ever she decides to perform bilateral mastectomy, she will be eligible for hormone replacement therapy, which is something that really brought everybody to a lot of fear when it was first published in 2018. But what we know now is that a woman who has removed ovaries and done the salpingectomy as well, they are not at a high risk of developing a breast cancer if they use estrogen alone, hormone replacement therapy for 5 years, provided she never had breast cancer before. Another possibility that we should consider to our patients is that whenever we know exactly the location the germline pathogenic variant is, we are able to, after an in vitro fertilization, define when we have a 5-day-old embryo to remove 10 cells and do the genetic testing in those cells. We have to construct probes to see if that variation is present. And we are able to define among the embryos which embryos are positive for the mutation and which are negative for the mutation. And usually those who are negative can be implanted and the others are frozen, as it is in most in vitro fertilizations that are done nowadays. And what's next in genetic testing? This is what we do now. In the United States, we have the possibility already of doing polygenic risk scores. These are really the future. And again, why do I stress so much about our countries and our populations? Because polygenic risk scores performed in the United States are only for individuals of a Caucasian origin. So they are not valid for us. We have to have our own. And I just wanted to show you quickly how this is important and how impactful it is. Let's use the example of CHEK2, which is a moderate penetrance gene that we talked in the beginning. Here we have a 23 to 48% lifetime risk of developing a breast cancer in general. So if we unite the CHEK2 profile to the polygenic risk scores, which are 90-something genes that they combine, and the Tyre-Cuzick, which is a model that includes not only data on obesity, but also parity and other factors as well. And putting this all together, we go from a range of 25 to 48% to a range that may go from almost 0%, 5%, to 90% risk in the same individuals. So this is very clear that only CHEK2 variant is not enough, doesn't bring us enough information. Most of them, okay, they're around here. But if I have a patient who is at a 90% risk of developing a breast cancer, I can be very sure that we can give to that individual the possibility of a bilateral mastectomy as a protective effect, even though for this individual who is 80% risk. So this is something that we have to learn and understand. What are the polygenic risk scores valid for our population so we can use in our individuals and not count with specifically those informations that are currently what we're using. That patient, we would have if sufficient evidence to provide risk-reducing mastectomy, and only screening wouldn't be enough clearly for that patient or for the family members. So this is what we want in the close future to our patients. This is what we want mostly for those who have moderate penetrance genes. PALB2, for instance, we're talking about 20 to 80 something percent risk. So it is very important for us to bring this to Brazil, to our countries, and to establish good healthcare policies. This is still something for the rich. Genetic testing is still not available for most of our populations. We have very few centers who can afford to pay to our patients. So we need national strategies. We need not only supplementary healthcare to pay for these exams, but also to public healthcare to pay for genetic testing and mostly for genetic counseling as well. And can we do anything to change this situation? We certainly do. We have a lot to do, but most of all, just think that if we are able to detect a germline mutation in our patient who belongs to a family that clearly looks as a high-risk family, we will be able to transform the natural history of the syndrome for the patient and for the whole family. And we have less deaths in those families. So this is what I wanted to share with you today. And I thank you very much for your attention.
Muchísimas gracias, Isabel. Una clase preciosa y que nos ha llevado de una punta a la otra de lo que es el gran espectro de los testeos germinales y realmente era muy lindo escuchar esto de la mirada y tratar de empezar a poner la mirada en prevención. Cuando nosotros en este momento recibimos una paciente joven con su cáncer ya diagnosticado y que ya teníamos toda una familia que nos hablaba de una gran carga familiar de cáncer y que podríamos haberla identificado previo a su cáncer, realmente para nosotros es una tristeza y está buenísimo poder trabajar en esto de la prevención. Hay varios puntos muy polémicos y que has hecho una gran profundidad en cada uno de ellos, pero vamos a empezar con algunas de nuestras preguntas. Nos acompañan nuestros panelistas que vamos a empezar a elegir. Les pido a
I
los
think
alumnos.
I don't need interpreter. I think I prefer just to hear the questions in
Bien.
Spanish. Okay, thank you.
Perfecto. Bien, no sé si ella me escucha, Ana, si vos no me traducís.
Sí, escucho bien.
Sí. Perfecto, perfecto, Isabel. Bien, vamos a empezar entonces a elegir las preguntas de nuestros alumnos que les pedimos que las hagan en preguntas y respuestas. Nos acompaña el doctor Martín Krasnapolsky, que es biólogo molecular del Instituto Roffo como coordinador, la doctora Ángeles Nico, ginecóloga y asesora genética en ginecología del instituto, y la doctora Vanessa López. Vamos a empezar, si te parece, Martín, ¿tenés alguna pregunta de nuestros alumnos?
Bueno, en realidad voy a empezar con una pregunta mía.
Muy bien.
Que se me generó cuando estaba escuchando la charla, que fue realmente muy interesante. Al principio, cuando comentaste los casos, especialmente el caso de esa familia que tenía tanto, digamos, pretest de tener buena enfermedad genética, pero con el estudio de paneles que le hicieron no encontraron nada. ¿No serían esos, por ejemplo, un candidato para hacer un estudio de exoma o de genoma completo?
Sí, well, can I answer in English? Okay. So we already did this with several families, and this would be what we call the third wave. That's what we expected in the third wave. We would expect to find another gene or something different in those families, but that's not the true for exome. So nowadays, I think the major technique we should aim for those individuals are whole exomes. I'm sorry, whole genomes. Yes. So I think we should aim for line and for retro elements and other situations that are not seen for with the current techniques that we are using now. And I hope to explain this for those individuals, because whole exome we did perform and we haven't found almost anything.
Thank you very much.
You're very welcome.
Un comentario respecto a la pregunta de Martín. Justamente muchos de nuestros pacientes nos preguntan esto, ¿no? ¿Por qué estudiamos tan poco? ¿Por qué no estudiamos más genes? ¿Por qué no me estudian todo mi genoma? ¿Por qué no estudian todo lo que yo he heredado? Y es explicarles esto, ¿no? Que muchas veces buscar más en realidad es encontrar más variantes de significado incierto, quizás es ir en detrimento de la calidad del estudio en los genes que queremos ver, y que nosotros vamos a estudiarle lo que tenga aplicabilidad clínica, lo que si encontramos algo, podemos hacer algo al respecto. No sé usted, Isabel, ¿cuántos ante una paciente con un cáncer de mama a los 40 años, 35 años, sin antecedentes familiares? ¿Cuántos genes ustedes estudian? ¿Estudian estandarizadamente estos 84 genes que nos mostraban? ¿Hacen paneles más pequeños? ¿Cómo manejan esto? ¿Qué cantidad de genes le gusta a usted estudiar en este tipo de pacientes?
Sí, el ideal para cáncer de mama hereditario es estudiar como creo que son 12 o 15 genes que son accionables, pero lo que tenemos es una colaboración con un laboratorio en Estados Unidos para que haga el precio. I'm sorry, I'm speaking in Spanish. Let's speak.
Está atenta nuestra traductora para...
I'm sorry, Celia. So the thing is, we have a collaboration with the lab in the United States, and in order for them to provide us the minimal cost, which is $250, they only give us the full panel. When we have a full panel, we will have uncertain findings very frequently, and most of all, if we talk about the variant of uncertain significances in the genetic counseling previous to the result disclosure, that's usually easy to deal with the patient. It's not a big problem. But what we do have to deal sometimes, because we're dealing with other genes that are sometimes not actionable, is that we have to also talk about this in the genetic counseling session, the pre-testing session. And sometimes we may find alterations, for instance, in a 35-year-old female with breast cancer. I found an SDHB gene. SDHB gene is related to pheochromocytoma paraganglioma syndrome. And it has nothing to do with what she has. It has nothing to do with the family history. And we found in her. And once we found in her, first of all, I needed to explain it to her. I needed to perform testing to see if she had anything. And we had to test her children. And her daughter, who was 18 years old, was a carrier as well. So at that moment, I don't know if I'm doing more harm to that patient or not, because we did find another cancer predisposition gene. And nowadays, we know from some studies, and there's a study we published in Human Mutation in 2018, which was on exactly families, individuals from the general population who entered the NOMAD database, which is a genome that is performed in Caucasian populations, mostly in Europe. And they have tested the genome for over 150,000 individuals. And what we did was an analysis of the TP53 gene and germline pathogenic variants in individuals who apparently had no cancer and who were above the age of 50, which is most of that population. And it was very interesting because we found from 1 to 2,000 to 1 to 3,700 individuals who carried a typical Li-Fraumeni syndrome mutation and had never had a cancer, and who never had a family history of cancer, because most of those individuals were there and entered the genome from other databases and never referred specifically Li-Fraumeni syndrome. That is very high. And we came to the conclusion that sometimes we are already biased when we have cancer genetics clinics. And I hope you're following me. If I see a patient in my clinic, usually it is someone who already had cancer, an atypical cancer, or had a family history of cancer. So all the people who come to me, they are already constituting a biased cohort. So when we look from the other side to the general population, we don't know actually what the gene does, or we don't know if there are other protective alterations or modifiers that are controlling that lack of the p53 in our population, in the general population. So this is a shift of knowledge that we have to have now. And that's why I insist so much, if your patient comes to you and he had no cancer and he has no family history typical of hereditary cancer, don't test him. You might cause more harm to him than benefit.
Perfecto, Isabel. Cada uno de los conceptos da para una charla en particular. Vamos a ir después en el curso de a poquito yendo en cada uno de estos temas tan interesantes. Vamos, Ángeles, ¿te parece? ¿Has seleccionado alguna pregunta?
Sí, yo tenía un comentario que hacerle, Isabel. Muchísimas gracias por la clase, muy linda.
Gracias.
Tuve la suerte de escuchar una clase tuya en Brasil, en el Congreso de Ginecología Oncológica, donde nos contaste toda tu investigación sobre el P53, y donde también habías contado este hallazgo, ¿no? de un grupo de pacientes que tenían mutaciones patogénicas en P53, pero que ni ellos ni su familia habían desarrollado cáncer, y cómo encontraron algo que cosegregaba con P53 y disminuía el riesgo de estos pacientes de tener difraumeni.
Perdón, Angie,
sí.
vos estás en canal español porque están escribiendo que no se escucha. Ponete en canal español porque si no, no te escuchan.
Perdón, voy a repetir.
La doctora Isabel, quédese en inglés.
Le estaba agradeciendo a Isabel por su clase y por otra clase que me dio en otra oportunidad, en la cual nos contaba su historia de toda su investigación que hizo sobre el difraumeni P53 y sobre este hallazgo de familias o de pacientes que tienen mutaciones patogénicas o que conocemos como patogénicas en P53, pero que no tienen antecedente familiar ni personal de cáncer, y que como probablemente P53 cosegregaba con otro gen que moderaba su penetrancia o su capacidad de generar cáncer. Y bueno, siempre que en la práctica médica en la práctica asistencial, me encuentro con los pacientes estos que vienen con paneles, digamos que pedidos casi por recreación, siempre me acuerdo de eso. Digo, encontramos una mutación patogénica y por ahí tiene otra cosa y uno tiene que empezar a indicar algo que quizás no haga falta, ¿no? La importancia de saber que todavía hay mucho que no sabemos y ser respetuosos con el conocimiento, eso me parece fundamental. Así que bueno, muchas gracias por esa enseñanza. Y después acá tengo una pregunta de Lina Núñez, que bueno, es la directora del programa universitario. Bien.
Hola, Nina.
Lina nos pregunta si están trabajando en el desarrollo de algún score de PRS, de riesgo poligénico, que tenga en cuenta la ancestría regional del Brasil y cómo validaría los scores conocidos en Brasil, los scores ya conocidos para la población brasilera.
Sí, es lo que queremos más, Lina. Creo que podíamos hacer una colaboración con Argentina también, porque necesitamos, para hacer un score de riesgo poligénico, necesitamos una población de base brasileña que tenga las informaciones que necesitamos. Entonces, si quieres una población de Inglaterra, por ejemplo, ellos tienen 100,000 genomes con, I'm sorry, in English, sorry, Celia. In most of the developed countries in the world and who have science that has developed a lot, they're trying to have their own population genome sequenced, and they have a lot of information. And we need that basic information on individuals regardless of family history. And usually the best is to have individuals without any serious illnesses in the base. So we need to have this in Brazil. So we're right now trying to get with the Ministry of Health. We have a program called DECIT. And in this program, we have already two major groups who are doing this. And the aim is to provide to our population this information within the next 5 years. And in case we're able to do that, we will be able to do that also in, for instance, breast cancer patients, and try to adapt it to our population. We're a step behind. It's a pity. I think we, at least here in Brazil, with all the complicated political situation and lack of funding for research, we're really having a big step back, and things are taking longer than they used to. And I think for you in Argentina is more or less the same. I imagine, and you're much better than me to say that, but I imagine your genomic constitution is completely different from people from Peru or from Colombia. So I guess you'll need to do the same if you need a polygenic risk score for yourselves.
Hola Isabel, acá Lina hablando, no sé si me
Lina.
escuchan. De repente me apareció un micrófono habilitado, un placer, la magia de la tecnología.
Hacerte hablar también.
Sí, es todo un tema de los PRS que no podemos aplicar en nuestras regiones, ¿no?
Sí.
El desarrollo completo de un score claramente requiere de una estructura que no tenemos, considero yo, en nuestro medio, y tal vez por lo que vos me estás diciendo a ustedes también les cuesta mucho. Yo me pregunto si existe alguna forma intermedia de pensar en una validación local de los scores ya desarrollados, buscando alguna corte de pacientes, digamos, buscando validar scores ya desarrollados, teniendo en cuenta la ancestría de cada lugar y tratando de ver el performance de los scores en grupos de distinto riesgo de pacientes. ¿Te parece que eso podría ser posible? Lo podríamos charlar.
Sí, sí, vamos a marcar un conference call, porque sí, creo que es muy, muy interesante lo que hay dicho, pero como tenemos como más de 500 genes de baja, as we have more than 500 low penetrance genes that may be involved in those polygenic risk scores, how would I know that those that are relevant to the North American population are the same as those that are relevant to our population? We might be missing a very important link, and we may have wrong information. So I think the best step is first to have the genome of our population, and then to go to the next step. But I would love to talk to you, please.
Bueno, te mando mail.
Wonderful.
Gracias, hermosa charla, Isabel.
Gracias, Lina.
Muchas gracias, Lina, por acompañarnos, y realmente parte de hacer esto, nosotros somos los hijos de Lina desde el punto de vista genético, así que estaría buenísimo poder generar todas estas redes. Vamos a seguir con las preguntas de nuestros alumnos, porque si no se nos van a enojar. Vane, tenés otra pregunta para la doctora Isabel.
Bueno, Isabel, hermoso escuchar tu charla. Bueno, hago un breve comentario y una pregunta para cómo manejas vos en tu unidad el timing, sobre todo cuando uno tiene que pedir en un paciente donde sospecha claramente que puede haber una alteración germinal. ¿Cuál es el momento? Digamos, a mí como oncóloga a veces se plantea cuándo es el momento adecuado para pedirlo, sobre todo en el escenario donde una paciente se enfrenta a un escenario metastásico de la enfermedad. Entonces, mi pregunta es si ustedes tienen algún lineamiento, ejemplo, no sé, si una paciente tiene cáncer de mama en neoadjuvancia, uno no duda que lo pide de entrada. Si está en un escenario metastásico, por más que yo tenga una alta sospecha de que haya una mutación germinal y sabe el impacto que va a tener en cambiar un poco la enfermedad a su familia, pero bueno, se reserva un poco el tiempo si no hay una estrategia terapéutica que esté soportada por el testeo germinal en una primera instancia, ¿no? Quizás en una segunda sí, pero en una primera instancia no. Sobre todo, si ustedes tienen un lineamiento de en qué momento pedir el testeo.
So the answer is immediately after the diagnosis. When you have a cancer diagnosis, that is the good timing to ask for a genetic test or a genetic panel. And why is that? First of all, we have a paper from the British Journal of Cancer, I guess, where they had 1,000 individuals. 500 received genetic counseling and testing at the moment of diagnosis, and 500 after the first line of treatment was performed. And the adherence was the best with the 500 who did it at the time of diagnosis, and all the screening of the family members for testing for other individuals who are at risk, and even the acceptance because the person is already at a huge stress when he gets a diagnosis or she gets a diagnosis, but that's the correct moment. And I can tell you from my personal experience, what we have developed at Hospital Syrio-Libanese is that at the moment, Arthur Katz, for instance, who is the oncologist in our group, who is the head of the group, he immediately shoots an email to me or calls me. I have a patient. I would like you to see this patient. I've already indicated the need of a genetic testing. I'm not the one who is asking for the genetic testing. And he tells Maria Isabel will be the one who will be asking you, and she needs to explain before collecting the exam. So I want you to go today or tomorrow or the next, but within a week maximum. So what will change? The person is in shock. We know that the person who just received the diagnosis, it has a huge impact, but it will help even the person metabolize the whole story and take the proper decisions. So we have the possibility, for instance, when we have a breast cancer that does not need to receive chemotherapy prior to the surgery. Usually it takes in Brazil 3 weeks to get approval from the supplementary healthcare, Seguro de Salud, se llama? I'm not sure. See. So within that time is the time frame I need to collect the blood, send it to the United States, have the result in my hand, and help the surgeon decide which surgery will be performed, just for breast cancer. But that is important for all types of cancer. And what we have very clear now, and you have a wonderful possibility in Buenos Aires with the genetic counselors to be able to work in this team. You as an oncologist and Dolores as a genetic counselor, for instance, it's very effective if you're able to pair up with each other and work together. In Brazil, we have 350 certified, board certified genetic medical doctors. We don't have genetic counselors, so it's a disaster. We are working like maniacs night and day, and still there's not enough people to do that. So I know Lina has developed an amazing program in Argentina that provides you very good genetic counseling and medical genetic counselors as well. So profit from it and try to do at the time of the diagnosis already a genetic counseling scheduled session with someone right after that.
Muchas gracias, Isabel. Vamos a seguir
Hay
con
una
las...
pregunta.
Vane, ¿te escuchamos?
Sí, no, que hay una pregunta de los oyentes que me pareció interesante, que es, cuando se pierde el caso índice, pero hay una historia familiar bueno, de cáncer en abuela, madre, tíos, ¿cómo lo manejan?
See, in individuals who are orphans, right? I read this question as well. It's very interesting. You're facing a situation that is called a limited family structure on both sides. If the person is an orphan and develops a cancer, then I'm completely for testing him. But if the person doesn't have anything, again, we'll fall in the same situation. We can find anything in that individual, and we'll never know if this has an impact or not. You have to be very careful on psychological aspects at that time. So yes, if I have someone who is an orphan and has a cancer, I offer genetic testing to that individual. And I don't care very much what age the cancer was diagnosed, because it can be just the top of the iceberg. And the other situation that this implies is the limited family history can be referred to individuals who are single child. The parents don't have many brothers and sisters, and families that we cannot see very well how the disease would segregate. So yes, we have to be very careful with that. And that is in the NCCN guidelines. Whenever you have a family history, limited family history, genetic counseling and genetic testing should be granted. I'm so sorry. There are so many questions. I wish I could answer them all, but...
Vamos a robarle unos minutos más, Isabel, no te preocupes, no vamos a hacer las 20.000 preguntas. Realmente es tan interesante y tan vasto esto, y tanta la necesidad de educación que uno tiene, porque tal como nos planteaba Vanessa, todas estas situaciones límite que se nos presentan ya en el consultorio con la paciente y uno tiene que tomar decisiones, tenemos que aprender mucho de esto. Hay varias cosas que habías apuntado, y sobre todo la calidad de los estudios, Isabel. Nos pregunta Nicolás Aguirre respecto a qué métricas de NGS considerarías aceptables en un panel. ¿Cuáles son las preguntas básicas que vos haces cuando te comunicas con el laboratorio respecto al estudio que recibís?
The best thing would be to call Martin, who is here right under me in the screen, who is the molecular geneticist, and show it to him. And because I cannot talk about a specific depth or coverage, it is the whole grouping of the situation. You have to analyze the method as a whole. And whenever I see a new one, I always call the lab, even though I know a lot of that. I also know that I'm very updated in clinical hereditary cancer, and I'm not very updated in molecular biology nowadays. So Martin will always know better than I will do. So I'll call him and ask, Martin, can you help me? I call our lab and I ask our guys. So Nicolas, you have to find someone to team with who could give you this information. And I don't know, probably you have such a wonderful web of help in Argentina that you're probably going to find someone who could help Nicolas in Argentina to give this information.
Lina ha generado, junto con el Instituto Nacional del Cáncer y el RACAF, varias guías que como que trata un poquito de homogeneizar respecto a qué nos tienen que decir los informes de los laboratorios, tratar de que sean del mismo idioma.
Yes, I've seen it. The last prediction that they had was wonderful.
Sí, nos ha ayudado muchísimo. Los laboratorios se han un poquito acomodado a esos lineamientos que dio Lina junto con su equipo, y justamente lo que nosotros hicimos con Martín y Nazaret, que no sé si nos acompaña hoy en el instituto, es decir, todo nuevo estudio que recibimos lo ve la gente de biología, se fija si el informe cumple y tiene las características y nos explican estas cuestiones técnicas básicas para nosotros poder tomar decisiones sobre esos estudios. Tenemos que tener en claro que estos estudios después tienen un gran impacto en el paciente, a nivel de tratamiento, a nivel quirúrgico, a nivel de su familia. Entonces tenemos que estar seguros del estudio que estamos recibiendo cumple mínimamente los criterios para considerarlo de calidad.
Voy a contar I'm going to tell you a story about a patient I've seen very recently, and she had one of the best labs in Brazil. She had a test, a BRCA1 test from 2019, and it was negative. And she had a very, very important breast cancer history in her family. And she came to me again with a breast cancer recently diagnosed at the age of 35. And I said, well, usually this lab is very good, but I'm not very sure. They didn't say if they cover alu insertions, which is hard to find. It's another technique. It was not very clear the last time I talked to them. So I decided to ask to that lab in the United States. And we found an insertion, alu insertion in that patient, and in time for her to do the bilateral mastectomy. And what does that show? That we, even if everything that this lab offers looks perfect, there was still one minor detail missing, and they didn't communicate me. I don't know, Martin, if you do alu insertions, which are rare. Usually you don't see them when you sequence. It's mostly in Portuguese origin populations, but we did find, and this patient was benefited. And I'm sure that whenever we start doing RNA-seq, we're going to have a bunch of new cases that haven't been diagnosed, and that we will find something mutated. So.
Muchísimas gracias, Isabel. Tenemos, no sé si Martín, ¿tenés alguna otra pregunta seleccionada? Ángeles, Vane.
Hay varias preguntas entre los oyentes que hablan de las variantes de significado incierto. O sea, es un tema que, como sabemos, es bastante complejo y como genera mucha curiosidad entre la gente. Una de las preguntas es, por ejemplo, vos comentaste que el laboratorio tiene la obligación de hacer el seguimiento de las BUS, pero acá preguntan específicamente si es una obligación legal o es una obligación más bien como ética, como que le corresponde, porque lo que decían es que acá en Argentina no existe esa obligación legal y que muchos laboratorios no lo hacen.
Exactamente, en Estados Unidos sí es una obligación legal, entonces es por eso que hago en Estados Unidos. Tenemos ótimos laboratorios en Brasil, pero no es una obligación legal. El duty to recontact es un termo que no se ha difundido en todo el mundo. Es algo que gustaríamos que fuese, I'm sorry, it's something that we would like for it to be true, but it's not everywhere that they do this. I agree with you. And I think it's a shame that they don't do variant of uncertain significance updates very frequently in most laboratories. I think it should be part of a necessity in most labs as well. And just keep in mind, variant of uncertain significance, actually, you cannot tell the patient to take any definitive measure with variant of uncertain significance. Please keep this in mind, because this is an error that we have not only in Brazil, but in the entire world. There was a poster recently in ASCO showing the mistakes that have been done. There's a study called PROMPT, And they analyzed this study to see how many patients performed prophylactic salpingo-phorectomies and who had variant of uncertain significance. And they had a huge number, a very high number. And some patients didn't even have alterations, and they were sent to salpingo-phorectomies even with negative results. So I really disagree with that attitude, and people should be very, very careful with variant of uncertain significances.
Muchas gracias, Isabel. Realmente el tema de qué información nos da el laboratorio, hay laboratorios que informan todas las variantes que encuentran, laboratorios que no las informan, nosotros siempre decimos que querríamos tener toda la información, nos hacen el comentario, estuvo el doctor Alex Prat de la Clínica de Barcelona dándonos la clase anterior, y ellos decían, bueno, que ellos mucha de la información no la daban al paciente, solo le daban lo clínicamente manejable. Bueno, cada equipo de trabajo tiene sus formas, cada uno tiene su pensamiento. Nosotros, y un poco lo que siempre desde el RACAF nos educan, es que toda la información tendría que estar disponible para el análisis, y nosotros también estamos tratando de hacer bases de datos de Argentina para también poder valorar nuestros perfiles. Pero bueno, no es fácil, ¿no? Todos los datos en este momento es poder. Entonces, bueno, cada uno tiene sus intereses. Bien, Isabel, vamos a hacerte la última pregunta para dejarte descansar y en honor al tiempo. Ángeles, ¿tenés alguna pregunta? Vane, Lina, está abierto tu micrófono también para despedirla a Isabel con una última pregunta. Tenemos aquí, había, bueno, varias preguntas respecto al score de riesgo. Vamos a ver. Aquí Nancy nos pregunta, dice, en ejemplo, en particular una mujer de 50 años, vamos a leerlo bien porque me quedé preocupada por el concepto, que ya ha vencido las edades de recomendación de oforectomía y mastectomía de reducción de riesgo. No se vencen. Si queréis explicarnos, Isabel, eso.
Sí, es muy importante. I imagine you're talking about a woman who has a BRCA1 and BRCA2 mutation, right? Is that it? Yes. So of a salpingo-phorectomy, you should perform at any age. It's not that you have to do between 35 and 40 for BRCA1 and for BRCA2, 40 to 45. No. If a woman comes to me at the age of 65 and has a germline variant in either BRCA1 or BRCA2, she should be eligible for a salpingo-phorectomy. She is still at risk. And the cancer of the ovaries may happen even at 70, 80 years old. The latest I told my patient to get a salpingo-phorectomy was a BRCA1 patient at the age of 78. She was still a runner. She was a very active woman, and she said, I want to live over 100 years old. And I said, wonderful, but you do have a BRCA1 variant, so we're going to remove your ovaries and trompas. Yes. So, and what about the breast? There is a very, very good paper that was published in 2017 that makes a stratification of risk with ages. And we can clearly see that BRCA1 is different from BRCA2, and the benefits of doing the risk reduction breast surgery is different with the two genes, and it most of all different in different ages. Let's start with BRCA2. We're not very sure if there is a benefit of survival if we do a breast cancer surgery in those individuals. This has to be clear to the patient. If the patient is very young, she's like 32 years old, and she had a sister who had a breast cancer at the age of 29, and she's really full of fear to see if she is going to develop cancer, and she has a BRCA2. Okay, it's a possibility, but we're not very sure if this surgery will overcome the benefit of just regular screening every 6 months. For BRCA1 is a bit different. Usually there is a very large benefit before the age of 50, as you mentioned. So it is a possibility, and there is this risk reduction that may be from 90 to 95%, depending on the technique that was performed. But when you talk about breast surgeries, what I do, and I think it's very important, is after performing the breast surgery, always ask your patient to do a magnetic resonance of the breast 6 months later. Why? Because not every surgeon who usually says that, oh, I removed all the breasts, not all of them do. Sometimes they leave a lot of tissue, and we never know if the cancer will occur in the tissue that was left. Of course, the aesthetic result is much better when you leave some tissue, but the best would be if it could only have 5 millimeters of tissue under the skin, which is very little, and it's very challenging on the technique. So not every surgeon is really trained to do that. So what I usually do, I take a look, and in case there is a lot left, I start all over again, the magnetic resonance altered by the mammography every 6 months. It's complicated. So it's good when patients ask you who would be a surgeon that you would think it's trustworthy. I have a full list of surgeons, but sometimes patients already come to you with the surgery and a bad surgery performed, unfortunately.
Yo soy cirujana de mamas, Isabel, así que vamos a tener toda una clase de cirugía de mama específicamente, y estoy totalmente de acuerdo con vos, que uno tiene que ser extremadamente cuidadoso, pero parte de lo que tenemos que entender es cómo usar las herramientas, hablar de riesgos a las pacientes, sobre todo de riesgo remanente. Hay veces que le hagamos de riesgo a lo largo de la vida y magnificamos algunas cosas. Uno tiene que tener mucho cuidado en cómo comunica los riesgos para que tomen las mejores decisiones, ¿no es cierto?
Sí.
Es así, es así. Bueno, Isabel, estaríamos horas hablando contigo, te vamos a volver a invitar, fue preciosa la charla, ya sé que da muchísimo para charlar. Nos vamos a ver el miércoles que viene para hablar un poquito de somático, viste, Isabel, que ahora como que empieza a pisarse lo germinal con lo somático, así que vamos a tener una clase el miércoles que viene de somático y una pequeña clase para cerrar. Te agradecemos muchísimo, muchísimo, Isabel, esperamos a los alumnos el miércoles que viene. Muchas gracias.
Bueno, gracias a todos también, con mucho gusto. Me gusta además Argentina, y gracias a todos en línea, Lina especialmente. Besos.
Chao Isabel, gracias.
Chao, gracias.
Gracias Lina por estar, gracias Vania, Ángeles, Martín, nos vemos el miércoles que viene. Chao, chao.
Chao.
Muchas gracias a todos.
Chao, excelente todo.
Chao, nos vemos. Gracias.
Chao Nico, gracias Ana, nos vemos. Hasta luego.